Good evening. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset, and I would like to welcome you to tonight's webinar on what becomes of the brokenhearted, presented in collaboration with Friends Health Connection. This webinar is part of a series of virtual education programs on heart health that we are offering throughout the month of February, which is American Heart Month. So can you really die of a broken heart? The answer is yes. The emotional stress from a breakup or death of a loved one can cause stress-induced cardiomyopathy, which can affect even those who are otherwise healthy. During today's webinar, we will learn more about broken heart syndrome, its causes and symptoms, and diagnostic and treatment options. We are pleased to be joined today by Dr. Oxana Ovakimyan, a cardiologist with Robert Wood Johnson University Hospital, Somerset, and the RWJBarnabas Health Medical Group. We will begin our webinar with about 30 minutes of a moderated discussion, and then we will open it to questions from our audience. So thank you for joining us, Dr. Ovakimyan. Let's begin by telling the audience, or having you tell the audience, a little bit about yourself.
Good evening, everyone. Thank you for being with us, and and hopefully you're in a nice and warm environment if you're home. My name is Dr. Oxana Ovakimyan. I'm a cardiologist, both consultative and interventional cardiologist, working with RWJ Somerset Medical Center, as well as practicing at Watchung Warren area. I have all kinds of interest in cardiology. I think it's the most beautiful field in medicine. Obviously, I'm a little bit of biased, but today particularly we're going to talk about the condition which is not well known in the general public, but has been becoming more and more frequent in our practice. Condition is called broken heart syndrome in a layman's term, but it's actually official term of the disease. Also called Takatuba Cardiomyopathy or stress-induced cardiomyopathy. Cardiomyopathy means weakened heart muscle, and there's a variety of types of weakened heart muscle. This particular one is related to stressful events typically, and those events could be both emotional stress or physical stress. Emotional stresses most often involve death of a loved one. That's most typical presentation, but it could be also any kind of other stressful event, losing a job, sudden financial hardship, could be even losing a large amount of money in a casino. It could be any kind of a large stressor which can create this sudden condition. The idea behind a condition is that you have a sudden weakness of the heart muscle. Normally, our heart muscle looks like a bullet, looks like a football, and it beats, normally through all parts of it. In broken heart syndrome, you have a very particular weakening where what weakens is the tip of the heart right here in the bottom, and it starts ballooning. We call it also apical ballooning syndrome. Instead of doing this, you have this part moving and this part just ballooning, not doing anything. The term which we use most often in medicine is called Takatuba Cardiomyopathy, where Takatuba comes from a Japanese word octopus trap. Octopus trap is a type of a vessel which they have created to catch octopi in the ocean, and it looks just like the heart would look when it gets weakened in the tippy top of it. It was first described in Japan, as you would imagine, in 1990, so it's a relatively newly recognized condition, although most certainly has been there previously. We just never kind of recognized it. With availability of more techniques and understanding of things, we now realize that it's a type of condition which was probably previously thought to be type of heart attack or something like that before other techniques were available for investigation.
So Dr. Ovakimyan, excuse me, let me just interject. So when you're talking about broken heart syndrome, and trying to explain what it is, just to kind of clarify, this is kind of a condition that is brought on by stress-induced. It's a stress-induced condition which causes kind of like an inflammation around the heart. Would that be a good explanation, or what is it specifically?
What is it? So it's a sudden change in a heart function. Somebody with a normal heart muscle function where it was pumping properly, all the muscle parts of the heart were pumping properly. Due to a stressful event, either emotional or physical, and physical stressor could be acute illness, emotional stressor could be a loss of someone, where you have a sudden, we don't understand exactly how it happens, but there are a couple of theories. Most commonly entertain ideas that you have a sudden rush of adrenaline, catecholamines, which creates a sudden stunning of the tip of the heart, and that part literally stops moving. You only have half of the heart, the top part of the heart, which beats properly, and the bottom part does not move at all. It's kind of just sits there. and you have a sudden weakening of the heart muscle, which can mimic symptoms that are typical of a heart attack. And even EKG, even changes on the blood work and electrocardiogram or any other parameters could be very, very, very similar to heart attack. And we'll kind of talk a little bit more of that. But it's a very particular condition, tends to be temporary and tends to resolve over time in a relatively short period of time, where in a heart attack, which presents exactly the same way, it is obviously not. It's a very different condition.
So you mentioned before, let's talk about how common it is, because you said it doesn't seem like it's as common, but you said it's more common than people believe. So how common is broken heart syndrome?
Generally, from all the people who present with symptoms and signs of heart attack, about 1 to 2% have broken heart syndrome.
Wow. Okay. Oh, that's good to know. So, and again, you also went into some of the things that cause broken heart syndrome. So can you maybe just to clarify for the audience, kind of really what causes broken heart syndrome?
Yeah, so typically it is associated with either emotional or physical trigger. Emotional trigger has been, in large studies looked at about a third of the cases are related to emotional trigger, loss of someone, sudden financial hardship, or something that's serious emotional trigger. A third of the cases are related to physical stressor, usually related to acute illness, bad infection, exacerbation of a chronic condition requiring hospitalization or something of that sort. COVID infection has also been, actually, we've been seeing more Takatuba Cardiomyopathy, this cardiomyopathy with COVID patients who are hospitalized. So any kind of acute physical stressor. In a third of the cases, we never find a cause. Like we go through everything. Has there been any stressor? Has somebody died? We cannot find it. So sometimes we can't find a cause. It's usually third emotional stress of some sort, serious emotional stress, third physical stress related to some sort of illness, and third, we never can find a reason.
So you mentioned something very interesting. All of us at some point of our life go through some emotional stress. I mean, like, let's take COVID, and you mentioned COVID. Not all of us are going to get broken heart syndrome. So, who is affected by it? And is it more common in women or men? Or if you can kind of like clarify that.
Absolutely. So it is much more common in women. Actually, in most studies where you look, about 90% are women. So it's actually quite rare in men. I've seen some cases, but it's rare. I mean, majority of time it's going to be a woman, usually over age of 65. Typically, it's postmenopausal women who are most prone to that. Obviously, a lot of postmenopausal women have stressful events of significant magnitude, but most of them don't get this particular illness. We don't exactly know what predisposes people, one person versus other. There are some familial cases where we see that the mother may have had it and the daughter could have it, so maybe some sort of genetic predisposition to it, but we exactly don't know the cause. But most often it's going to be a woman, and average age is about 66 in most studies. So it is usually postmenopausal women who are most prone to this.
So do you, what triggers it? Like, what is going to why is one person going to have it and not another?
Well, that's a very good question. We don't really know that. We don't really know that because we don't even exactly understand how it happens. As I said, the most common theory behind it is that we have a sudden rush of adrenaline or typical hormones, which create the stunning of the heart muscle. But there are other theories. There's other theories related to maybe spasm of the artery, where the arteries of the heart tighten up really tight and cut off the flow to the heart muscle. And there's other theories that maybe we have a little bit of actually thrombus forming in the artery and it dissolves by the time we get to look at it. So we don't really exactly understand how it happens. So we most certainly don't know why it happens to some people than the others. So it's somewhat mysterious disease. It's very interesting. And, my mentors, when I was in training, saw this very rarely. Now at least once or twice a month, there'll be a case coming in with this. So it's definitely more common. Is it related to us recognizing it more and we just know how to diagnose it and we see it more? Or is there more stress and more things going on that where people actually have it more often? So that's definitely a question out there.
Interesting. So I think you've touched on this a little bit, but I really want to kind of hone in on this. What are the symptoms of broken heart syndrome?
Very good question. So typically are very similar to symptoms of a heart attack. Most often people would describe chest pain. And it doesn't always have to be pain. It could be all kinds of ways people describe it. Some people describe it as pressure, some people describe it as burning, and doesn't have to be in the left side or right side. It could be anywhere in the chest, could be vague, could be pinpoint. Typically, about half of the patient also describe difficulty breathing, shortness of breath, and a few people actually can even pass out. You know, passing out is a third most common symptom of the disease, but most often it's chest pain.
Okay, so then how is that diagnosed then?
So it's actually quite interesting. So let's say, you know, you're a 65-year-old woman, you just, you know, unfortunately lost a loved one, and, you know, after a funeral, you start having chest pain. Okay, I've had that scenario probably at least a dozen times in my short career. You come to the hospital, you get checked out right away. You may have, you know, high blood pressure, low blood pressure, it can vary. You know, you get an EKG, and that's a cardiogram where we put little leads on your chest and we create electrical picture of the heart muscle. That would usually be abnormal, and it could be abnormal in a typical pattern for a major heart attack. If that's the case, and that's the case for the half of the patients, then you'll be rushed into the cardiac cath lab, a facility where we put a catheter from your arm or your leg. It's threaded all the way to the heart, and we inject dye in the arteries of the heart and take pictures of the arteries to see if there's a blockage, because that's what typically would be the case. Everybody would suspect that. But in about 1 to 2% of cases, that would not be the case, would not find a blockage, but we will find that arteries are normal. They're all, you know, the flow is normal. There is nothing to suggest that you had a heart attack. Then we take a picture of the heart muscle function, and we will see that you have this particular pattern where the base of the heart is moving very rigorously, and the tip of the heart is not doing anything. That typical pattern we discussed. And that will be pretty diagnostic that you have arteries, which are not consistent with a heart attack, but you have a typical picture of a significant weakened heart muscle. Usually by then, we also get some blood work back, and the blood work would show signs of heart damage. So an enzyme called troponin, which is commonly done, will be released in the bloodstream. There's any kind of damage to the heart muscle. And it could be from a heart attack, could be from any sort of damage, and that will be elevated. So essentially you'll have everything of a heart attack, but without a blocked artery to explain it. That would be your Takatuba Cardiomyopathy.
Okay, so then, we diagnose it. So then how do you treat it? What are the treatment options for it?
Yeah, so it depends on how sick you are. So most patients are generally not very sick, meaning that they don't have very low blood pressure, don't need to be on special medicines to keep up their blood pressure, don't need to be in an ICU setting. But about 10% of people can be quite sick. So if you're not a lucky one, that you're not that sick, you just have chest discomfort, we did a catheterization, you don't have a blockage, we figured that out, your blood pressure is okay, but you're still having pain. So we treat you with medications. Medications usually would include mostly medicines which relax the heart muscle, known as beta blockers, something like metoprolol, some people take it, or carvedilol, medicines which slow down the heart rate and relax the heart muscle and help to strengthen the heart muscle. Additional medicines usually include medicines from a group called ACE inhibitors, something like lisinopril or ramipril. I'm sure some of the patients who are on our line may be taking those. Those are typically known as blood pressure medications, but they have a very particular effect in helping to improve the heart muscle function. Typically, you would be placed on those medications and you'll be monitored in a hospital setting for a few days because, even though you may have mild version of the disease, it can progress, it can get worse. So you have to usually be in a hospital for a few days until we see that the heart enzymes are not worsening, they're getting better, that we see that initial changes on the electrocardiogram are improving, that your chest discomfort has resolved, and there's nothing else going on which needs additionally to be addressed, like an infection or something like that, which could have been a trigger in the first place. So those things have to be all addressed. And typically, in most studies, when they re-looked at the muscle function by the echocardiogram and ultrasound of the heart, we see that in most patients, approximately 6 days later, the function starts getting better. It kind of rebounds. And 2 to 4 weeks later, more than 90% of patients have complete recovery of heart muscle function on medication. If you are an unlucky person who had a more severe version of the disease, where you came in quite sick, like if you had a major heart attack, same kind of concept. You have a sudden weakening of the heart muscle and it gets so weak that it's unable to pump enough blood to the rest of the organs. So you can have a shutdown of the other organs like kidneys and liver and so forth. So you may need very special medicines to keep up the blood pressure, called pressor medicines. You may need to be in an ICU setting. And a few patients can even die from this acutely. You could have such a weakening of the heart muscle, you can have irregular heartbeats, and that can be detrimental and could be fatal. Some patients require some support devices, what are called mechanical support devices, which are literally little heart pumps, which are placed from the leg to pump the blood to take over the heart function until the heart function recovers. Because as we said, in the vast majority of patients, it does recover pretty rapidly.
So then you mentioned a lot of different tests. So can you tell us about, I know we offer a lot of tests here, but can you tell us a little bit about the cardiac testing and treatment services that we have here at Robert Wood Johnson Somerset?
Absolutely. We pretty much have everything you would want or need. The only thing we cannot provide at Somerset Medical Center would be an open heart surgery. All the other services related to cardiac care are readily available. Obviously, we have all the gamma ray of blood work required to diagnose and figure out what kind of heart disease you have. We have options of electrocardiograms, variety of ways. We have a telemetry monitoring where we can monitor your heart rate continuously while you're in a hospital to make sure you don't have any irregular heartbeats. We have availability of ultrasounds of the heart where we actually take moving pictures of the heart and see if you have any problem with the leaky valve, narrow valve, see if you have any weakening of the heart muscle, including the disease we're talking about. And we have availability of cardiac catheterization where we look to the arteries of the heart of the catheters from the wrist or the leg to assess for any blockages and treat them if necessary with stents. Stents are little metal kind of a tubes which we place in the artery and push the plaque away and restore the flow.
Okay. Thank you. So I think you also touched base upon this a little bit when you were talking about all the different treatment options, but what are some of the complications that can be caused by broken heart syndrome? Could you
so complications tend to be more of an acute, like in the midst of the acute presentation when you come in. If you have a severe version of the disease where you have a really weakened heart muscle, you can have what we call cardiogenic shock, meaning that the heart muscle is so weak it's unable to generate enough blood flow to feed the vital organs, including the brain. People can pass out, can be fuzzy, can really think, can be confused. You can have a shutdown of the kidney function requiring hemodialysis. You can have a shutdown of the liver function, which could be also detrimental, lead to a problem with the production of the protein and production of factors which make your blood clot so people can bleed. So all those systems can shut down, and each of them will have its own complications. From the heart standpoint itself, the weakening of the heart muscle can also result in irregular heartbeats, something we call ventricular tachycardia or ventricular fibrillation. They are dangerous heart rates from bottom chambers, which can be fatal if not addressed immediately with a shock, where we restore the electricity of the heart with a shock you would see on the TV on the shows. Those would be the most severe complications, and some people have a shock situation, kind of persistent, requiring a mechanical support where we have to put little pumps in the leg to pump the blood to take over the heart muscle function. Those usually happen in less than 10% of patients. So vast majority of patients would not require those extreme measures and would just need medications to support the heart function and treat the underlying cause, which potentially could have caused it, especially if it's an infection or something of that sort. Because treating that will be also important to take over the stress from the heart.
Okay. So what can individuals do to prevent broken heart syndrome? They might not be able to prevent the stressful event in their lives, but is there anything that they can do, any strategies you can offer?
Yeah, so we don't really know if having a healthy lifestyle and following all the heart healthy recommendations, which we'll discuss a little bit later, will have any particular effect in this particular condition. Again, it's a little bit of a mystery condition where we still have a lot of unknowns and we're still kind of learning about it. So it's only about 30 years old in terms of us never knowing they ever existed. So it's going to be hard to somebody who's never had anything like this to be able to prevent it in a particular fashion, because you may never be one of the person who will ever develop it. But people who have actually had it before can have it again. Recurrence are not unusual. Yeah, on average, somebody who had broken heart syndrome has about 2% chance every year to get it again. So people who had it, they usually need to be on certain medicines lifelong sometimes to prevent it. I personally known the patient who had it 4 times. So it can come back, and with seen recurrence is usually the second more often, but some people can have many times. So mostly will be people who've had it before to try to minimize the type of event which caused it, if it was a stressful event. I had a lady who had it several times, it was related to a meeting at work. Every single time it was some sort of a very stressful meeting at work, she would have chest pain, come to the hospital, and she had it. So it doesn't have to be always like a stress that you would think, like somebody's passing away. It could be even just related to your job if it's a really stressful job. So somebody like that would recommend it just to find another job, to try to avoid those situations.
That's interesting. So would you say then, like, just taking stress in general, because it does seem with this condition, it seems to be a mind-body type of a connection.
Yeah.
So would some of the stress relieving preventions be like, obviously, maybe exercise, some yoga, or even maybe therapy if it's, that severe of a case? Is that maybe some of the types of things that would be recommended?
We do recommend that. We do recommend meditation. We recommend yoga or Pilates or anything which will kind of take your mind off things. Does it work? We don't know. Unfortunately, nobody ever studied it, but theoretically, given that circumstance which usually happens with, it should have positive impacts. If you look at other cardiac diseases, heart diseases, yoga has been proven to be effective in those where stress is also a factor. So it probably works. So, I mean, it's definitely not going to hurt. So we do recommend people to try to find ways to reduce stress, sometimes with help of medications if they have anxiety disorder. Because people who have anxiety disorders, for example, have a higher risk of that. So there's definitely some sort of component of mind-body connection, as you mentioned. There's even people who have headache disorders, migraine disorders, also have a little bit higher incidence of that. So there's definitely some sort of connection. So recommending that is helpful, is definitely helpful. But to what degree, time will tell.
Okay, so I want to switch over to the body part of this. So you mentioned earlier, what are talking about like heart health? What are some general tips that you can give our audience for promoting your overall heart health?
Oh, absolutely. That's my favorite topic. If you are a healthy person and want to prevent heart disease, the main thing you do is to address your lifestyle. There will be diet and exercise. In terms of diet, from standpoint of a cardiologist, the best diet you could ever be on would be a plant-based diet, some sort of vegan diet, especially if it consists of mostly low-fat, whole foods. Anything which can be eaten in its raw version without any processing is always much better for you. So trying to focus most of your diet on plant-based items, avoiding red meat specifically and dairy are very healthy for you. And the closer you can get to that, the better. You don't have to be vegan tomorrow. It's an incremental benefit. The more of it you do, meatless Mondays and Thursdays, and meatless Mondays, Thursdays, and Sundays, and slowly increase amount of the vegetables you eat in your diet, vegetables, grains, and minimizing animal products, including chicken and fish. Vegan diet does not involve any animal products whatsoever, including chicken and fish. Nobody really looked to compare specifically if eating fish once or twice a week is as good as being vegan. It's probably okay. Out of all the things, like if you have to have animal products, fish is probably the best. Second best would be chicken. You should avoid red meat altogether. Red meat really has very little value from cardiovascular standpoint. It's very tasty, but not really good for your heart. In terms of exercise, we usually recommend, by the American College of Cardiology, at least about 25 minutes of moderate activity a day, which involves fast-paced walking. Gardening is actual moderate activity. You would never think. It's actually pretty intense. You're on your knees. You're doing a lot of activities. Playing sports, also very helpful. Cycling, anything you could do. I mean, obviously with this weather, you really can't do anything unless you have something at home. But if you have stairs at home, it's a free stepper. You can use the stairs. Try to do 10, 15 flights of stairs at home if you otherwise have no ability to go out. Now with COVID, there's no gyms. I mean, it's been very difficult. I mean, the majority of my patients have gained weight because we're home, we're cooking more, which is good, but we're also eating more, we're less active. So it's definitely requires some extra mindset to kind of pay attention how much we're eating, how much calories we're taking in, and try to eat healthier stuff.
Yeah, great points. Thank you. So now, what are some of the important screenings that people should be getting to help identify early signs of heart disease? I know we always talk about know your numbers, right?
Yes, know your numbers, exactly. So it's very important to be aware of your numbers, right? So to know your blood pressure, to know your cholesterol levels, to know your sugar levels. For the blood pressure in the past, we used to kind of have a cutoff of 140/80, the top and bottom numbers. That has changed. That has changed approximately 3 years ago. Now it's 130/80. So if you have blood pressure regularly, you go to your doctors and they tell you it's 135/75, you have hypertension. So the cutoffs have changed. So we are trying to aim lower and lower, especially in the younger population. You know, somebody who is 80 or 85 may aim at a little higher number, but somebody who is 40, 50, 60, we try to keep their blood pressure as low as we can. The lower we keep it, the less we have damage long-term with complications to the eyes, the heart, the vessels, everything. So the lower we can keep the blood pressure, the better. So make sure that whenever you're seeing your primary physician or whenever you are at any fair or going to a pharmacy and checking your blood pressure, check the numbers. If you're seeing that numbers are in 130s, that's not normal. Because I have lots of patients coming in and like, my blood pressure is normal. That is not normal. Normal is at 110, 120. That's normal. Anything over that is really not normal and have to be looked at. Doesn't necessarily mean you need medications, but we may have to have more intensive lifestyle changes which have to be addressed to try to lower that. So that's very important. In terms of cholesterol, you know, you got to make sure that your doctor checks it every once in a while. Some people need it once a year. Some people need it every few years. It really depends on your risk factor profile. Let's say your mom and dad have heart disease in early age. You will be somebody who needs more intensive monitoring, you know, more close monitoring of those things. And if your numbers start creeping up, and usually with the cholesterol numbers, we try to keep the total under 200. And the bad cholesterol, called LDL, under 100 ideally. If they start creeping up again, adjustments to the diet and lifestyle have to be made, and some people need to go on medication sometimes. We have more tools now for screening, which we didn't really have, you know, just 2 years ago. For example, calcium score. I use that test very frequently. It's a type of test where we do a CAT scan of the heart without using any dye with a very low amount of radiation to see if somebody has calcified plaque in the arteries of the heart. Whenever we develop cholesterol buildup anywhere in any artery, calcium ultimately goes in there and kind of stabilizes the plaque, so it's more stable. And the calcium can be easily detected on a CAT scan. And when we do that, and if you have any plaque, we can actually quantify it and put a number to it. And you know, we know what an average number should be for any person, a 45-year-old man, an 85-year-old woman. So we have an idea of what an average should be, what is low, what is high. So we can put you in a certain category. Are you a high-risk person, low-risk person, or average-risk person? And that can help also dictate what kind of numbers we want to achieve with your cholesterol, your blood pressure, and so forth. So there's a lot of other tools out there available now, which a lot of doctors would use to try to personalize the care, personalize prevention.
Sounds good. Okay, so you know, before you were talking about how, you know, broken heart syndrome, there's chest pain, there's tightness. So, you know, what are some important symptoms of serious heart problems that are going to require you call 911 for immediate medical care?
Yeah, so it also would also vary, right? If you're a 15-year-old girl, it may be a little bit different, but you know, I'm assuming most of our SNDs are a little bit older than that. Generally, any symptom related in your chest would be of a concern, specifically if you have chest pressure, chest burning, or chest pain. And it could be described all kinds of different ways. Any discomfort in the area which you have not had before. If that discomfort gets worse if you walk around or do anything, that's even more concerning, because any kind of a heart pain tends to get worse when you make the heart work harder. If the pain is related to breathing, like if you're taking a deep breath or coughing, it gets worse, that could be related to your lungs or lining around a heart and lung. But all those symptoms, any kind of chest symptom like that would generally require either an emergency room visit, urgent care visit, or call to your doctor, you know, depending on how bad you feel and what kind of history you have. Other symptoms are also very important, specifically if you suddenly cannot breathe, if you have labored breathing, those are also very concerning. If you wake up in the middle of the night out of breath, also very concerning. We should also monitor other symptoms such as sudden dizziness or lightheadedness, where you feel like you're going to pass out or get lightheaded. Those are also symptoms of concern. And in some instances, people can also have, you know, heart-related issues, specifically heart attacks, with very atypical symptoms such as just nausea or vomiting. You know, it could be just that. So if you have any sudden onset of a symptom which would not be explained otherwise by anything you already know, you should seek medical attention.
Great. So, and if somebody has broken heart syndrome and they're getting chest pains, they shouldn't just assume, correct, that, oh, it's broken heart syndrome, I don't need to go
Definitely
to,
not.
okay.
Yes, definitely not. And even if it's broken heart syndrome, it has to be treated, right? Because as we said, there is probably about 10% of people who can die from it if not managed properly in the acute setting. So it is also a serious condition. It is a good condition in the sense that it's most often resolved completely, but in acute setting, it could be as dangerous as a heart attack.
Great. Well, thank you for clarifying. Now, some people may be hesitating too about coming to the hospital during the COVID-19 pandemic. So can you maybe explain and share what are some of the precautions that, for example, Robert Wood Johnson University Hospital Somerset has taken to ensure patient safety during this time?
Absolutely. I think Robert Wood Johnson generally and Somerset Hospital have taken really good precautions and have learned over this last year to try to maximize the safety of the staff and patients and everybody else. Everybody who comes to the hospital, including staff, gets checked upon entry. We have a questionnaire. We ask if we have any symptoms. We ask if we traveled anywhere. And the questionnaire changes according to whatever new knowledge we have that particular period, because this is an evolving thing. We're learning every single day something new. We get temperature checks to ensure we have no temperature. We are encouraged to not come to work if we have any concern for any upper respiratory type of symptoms. Nobody gets penalized for that. So everybody knows that if you're not feeling well, you don't come to work, and that's being followed. From the patient perspective, all patients who come to emergency room, they tend to be isolated by themselves. They don't have a neighbor next to them who hasn't been tested. All the patients who get admitted to the hospital, every single one gets tested for coronavirus. So we know that whoever is in a room does not have coronavirus. If they do, they're in a special unit where they cared appropriately with nurses and physicians who are trained in dealing with this condition, with appropriate personal protection devices and so forth. So with procedures the same way, every single person coming in for any procedure to the hospital gets tested for coronavirus and is assured not to have a procedure done. The staff and the entire staff of the hospital wears masks at all times. Any procedure which we have a little bit higher risk of exposing somebody to coronavirus, we wear N95 masks, thicker, more protective masks, and we're now wearing mostly shields as when we're in contact with patients. So we're doing everything CDC and our colleges tell us to do. And we're very up to date. We continuously adjust to whatever new recommendations come in. And from the perspective of the patients should not be scared to come to the hospital. If you have symptoms which are concerning enough for you to even think about coming to the hospital, you should. We will take all precautions to ensure that you are not to get coronavirus while in the hospital and get all the treatment you need, for whatever condition you're coming in with.
Thank you so much. Now, I know I've been asking you a ton of questions. So right now, I'd actually like to open up the questions to our audience. If any member of our audience does have a question for Dr. Ovakimyan, please post that in the question and answer section of our webinar. We do have a question already posted. So can you please explain that test again that was in connection with cholesterol? Is it a CT scan?
Yeah, I think this is a question about the coronary calcium score. Yes, it is a CT scan. It's called, the full name of the test is CT coronary calcium score. It is actual CAT scan of the heart. It does take other parts of the lung as well. We can't just cut out the heart when we're doing the imaging. So we do get additional information. Sometimes people have nodules in their lungs or something like that, which can be picked up. But the idea of it is to image the entire heart on a CAT scan and look to see if there's any calcium in the arteries of the heart. We could also get additional information too. We can see if we have any calcium in the valve, aortic valve, what type of valve, or other valve. We can see if there's any calcium in the aorta, main vessel coming off the heart. We can even sometimes measure the size of the aorta, main vessel, and some people it could be enlarged. So we can pick up some other things, it's like a bonus information we can get. But the main idea of the test is to try to see if you have any calcified plaque in the arteries of the heart. We all eventually develop plaque. There's no 90-year-olds walking around with no plaque. We all have plaque at some point. We all develop it, and we start developing in our teens. But the calcification of the plaque happens later in life. In women, it mostly starts at age 60, 65. In men, it usually starts at age 55 or 60. And if we have somebody who has family history of heart disease, let's say mom or dad had a heart attack or a bypass or something major cardiac at an early age, let's say at age 45 or 50, and I have a patient coming in at 40 or 45 and they're they're concerned. They may have a little bit of elevated cholesterol, but they're doing their best. They're exercising, they're eating well, but they were looking to see if there's anything else they can do to try to figure out if they have inherited those genes. Because obviously we cannot test for those genes. We don't really exactly know them. There is a multitude of them. So we have to look for the consequences of those genes. So the calcium score is one of the later things we do. And let's say the 45-year-old man has a calcium score which is elevated. It should be 0. Should be no calcium at that age. And if the score is, let's say, 100 or 200, that's quite elevated. It means that the process in this person has started well before expected time. And that person is much higher risk of developing heart conditions such as heart attacks and heart failure and other heart issues, relatively sooner in life than it would be expected. So somebody like that would be much more aggressively treated, usually with medications to lower cholesterol to very low levels, will be advised to eat much healthier and would have a good reason for that, very good motivation, and the same with exercise. So it helps to distinguish a person who may look very healthy, but actually has developing process a lot sooner and a lot more aggressive than would be expected.
Okay, thank you. So our next question is, for broken heart syndrome, do we know if it's due to acute stress or ongoing chronic stress?
It's, from what we know, it's acute stress. It could be a combination of a process. You may have a lot of stress and then kind of final straw, but it tends to be an acute stressor, an acute stress of an acute illness or acute stressor of an acute event. Most typically, what I've seen, it has been a death of a loved one.
So now you mentioned that broken heart syndrome was temporary and it can be, it can be cured, but are there any long-term effects from having had broken heart syndrome?
Typically not if you had complete recovery of the heart function, but not absolutely everybody does that. So about 95% or so of patients do have complete recovery of the function, assuming they don't have recurrence. Again, we have the issue of recurrence. So you kind of sometimes people live with a fear of having it come back, and it could technically, so it's somewhat justified. But there's a small portion of patients who do not completely recover the heart muscle function, so they technically could develop heart failure, where you have a weakened heart muscle in a long period of time, could have a symptoms of congestion, swelling of the legs, shortness of breath, cough, and things like that. So these people have to be treated like we would treat any other person with a weakened heart long-term with several medications and very close follow-up.
Wonderful. Okay, that's great to know. Any more questions for Dr. Ovakimyan? Okay, maybe not. Okay, so well, I guess if there's no other questions, I want to thank Dr. Ovakimyan for the great information you shared with us this evening. This is going to conclude our webinar, and please remember that the opinions expressed here by our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset's cardiology services, you can visit our website at www.rwjbh.org/Somerset. And for more information about our upcoming events, when you're on our website, just click the events section. We do have another webinar coming up next week, February 24th. That is also on abdominal aortic aneurysms. So we hope you've enjoyed our webinar this evening. We want to thank all of you for coming out, and once again, thank you, Dr. Ovakimyan. Have a great evening, ladies and gentlemen. Take care.
Have a good night.
Good night.